Welcome you to our webinar on accelerating discovery, the critical role of secondary data sharing in health research. And this is something I'm incredibly passionate about as a clinical researcher, but also as the director of a research centre. I think that it's incredibly important that we don't waste our precious research data for the sakes of our patients, for the sakes of the researchers, and also for, the health services that, not just patients, our communities, our health services, and for the researchers, that we look at how we can make best use of research data. I'd like to start by acknowledging the traditional custodians of the land on which we're all meeting and pay my respects to elders past and present. We extend respect to any Aboriginal or Torres Strait Islander peoples joining us today. And just a little bit of an outline, a webinar recording will be made available after the event and will be posted on the Monash Partners website. Please feel free to introduce yourself in the chat below, and you can use the Q&A function to post any questions that you have for Rhys or Matt, our speakers. And please use the hashtag MP Event 2026 across any social media if you're going to post anything. So without further ado, I'm going to introduce Dr. Rhys Williams, the Research Data Specialist at the ARDC. And Rhys, I will let you add anything that I miss, but Rhys has postgrad qualifications in molecular biology and adult education and a career spanning medical research, technology transfer and university management. He joined the ARDC in mid-2020 and is part of a small team managing the HeSANDA program, which is especially supporting the HeSANDA nodes of which Monash Partners sits as one, Monash University and Monash Partners. He also provides advice and support to researchers and research institutions to facilitate the best practice in the curation, management and sharing of data. So Rhys, we are so delighted to have you join us today. Thank you very much, and we're looking forward to hearing you speak about data sharing.
Thank you, Carol. I'll share my screen and make a start, and I presume that that's working okay for everybody?
Yes, it is. Thank you.
So I'm going to speak a little bit about the ARDC and HeSANDA HDA. Apologies to those who may have heard some of this before, but I'll just give a general introduction, and then I'm going to then hand over, and Matt will talk about the more practical and technical details of how you as researchers can access these resources through Monash Partners. I'd also just like to acknowledge I'm on Kaurna land today in Adelaide. ARDC has 100-odd people all around the country, and we acknowledge and celebrate the first Australians on all the lands that we live and work. ARDC is one of the NCRIS facilities funded by the federal government by the Department of Education, which always seems like a funny place to put research infrastructure, but that's where the money comes from. And unlike some of the others listed here, which are usually around large physical facilities, ARDC's focus is on research data infrastructure. The idea being that we're going to do the sort of thing that Carol just said, make it possible for researchers to make the best possible use of the data they have so that they can accelerate their research work and accelerate the translation of that into societal benefit. ARDC is across all disciplines. Obviously, today we're talking about health data. One thing that's helpful to know, perhaps, is that we have three sort of focus areas. We call them the People Research Data Commons, the Planet, etc., and the HAS, Humanities and Social Sciences and Indigenous. So we don't just work in the health space. Today, all the activities that I'm going to talk about come under what we call our People Research Data Commons. HeSANDA, for those who wonder what that abbreviation, Health Studies Australian National Data Asset, that actually started quite some time ago before we'd set up the People RDC structure, specifically to build national infrastructure to allow researchers to access and share data from health studies. And we started with clinical trials, as I'll show you, but we are moving into other types of clinical studies, and I'll talk about that towards the end. To get there, though, we had quite a long consultation process with key players like the NHMRC, the ARA, and the MRFF, and all the government bods, and then researchers around the country. We developed metadata standards, consistent procedures, and policy development, and of course, we built a Health Data Australia, which we'll talk about in more detail shortly. But just to emphasise, it wasn't just about building a piece of software. There's a lot of other bits that go with it. To give you a sense of that time frame, it started in 2020. As soon as I joined ARDC, I was kind of thrust into this project. We did some co-design work. We established the HeSANDA nodes, of which Monash is one. The software itself, Health Data Australia, was launched in the middle of 2023. And then we've continued to co-invest in those nodes through until the middle of this year. And then importantly also, we've now moved into the cohorts space. So putting cohorts data into HeSANDA. That project started in the middle of last year and will run for a couple of years. This photograph, and if you look carefully, you can probably see our friend Matt Ishak hiding at the back. That was the launch of Health Data Australia back on 18th of July in 2023 in my hometown of Adelaide. Mm. What what is important and what makes this work is the network of nodes. There are nine HeSANDA nodes, we call them, around the country, covering around 72 partner organisations. You'll notice that most of them are based around the health translation centres, the ARA centres, of which Monash Partners is one. But there are a couple of groups. There's the mental health node and the cancer cooperative trials node, which are more obviously discipline focused, and in that case run by research networks in those respective fields. That's just to give you a sense of the coverage. For some reason, I'm having trouble here. Um, I, Health Data Australia was the major output of that work, and I'm going to leave it to Matt to describe how Health Data Australia works. But critically, there are two components. It's a catalogue of clinical trial data sets, soon to be other types of health data sets. It's not a catalogue of the trials themselves. Obviously, that's what ANZ is, but it's a catalogue of the data sets arising from clinical trials that are available to be shared for secondary use. And the second part is that it's a request system. So you search the catalog, much the same as you would search any other kind of a library catalog or Amazon, shall I say. Find something that you want. You can click access the data. That will describe this a bit more detail. You need to fill out a data request form. And critically, that request, even though it's managed by a workflow that HDA has electronic workflow, the request goes back to the nodes, to the originator of the data, the data provider, the data custodian, if you will, and they're the ones that then make decisions. Will this data be available under what sort of conditions? So it's subject to the governance arrangements that are already established at the node. Um, so that's hopefully a bit of a view of HDA, where we got to with HDA, and I'm going to leave it to Matt to sort of go from there to talk about how that will actually work in practice for someone like yourselves, a researcher at Monash, either wanting to put data in or wanting to make a request to get data out. Um, you can imagine that it's not just if you build it, they don't necessarily come, and that's what we found. And of course, the clinical research ecosystem is much more complicated because there are a lot of other things that need to go around to support data sharing. A big one is ethics and consent. So I just want to quickly tell you about a couple of things that ARDC has done, some of which is relatively new, to try and oil some of those wheels that together make up the cogs of the clinical research machine. The first is that we worked with CTIQ on two projects. They're informed patient information and consent form. I'll provide links at the end. I've got all the links for these things in a document which I'll share in the chat when I'm finished. Some of you may know about the informed PICF, but it's been designed as patient-centered and simplified. But most importantly, it includes upfront wording around consent for data sharing, which has not always been highlighted or included in PICFs, but it's important to get that up front. And it comes with a template and a guide of how you would do that. And very recently, it's actually been officially endorsed by the NHMRC, and it's being rolled out by some large organisations. New South Wales Health, for example, have now evaluated and have rolled it out as the required PICF across all of their sites. I know the Peter Mac are using, I think the Austin are using it. So that's an important piece of the puzzle. Another important project is what they've called the Clinical Research Data Sharing Frameworks Project, which has produced a suite of resources I'll talk about a bit more in a minute to support all of the components of data sharing, including ethics committees, for example. Without going into technical details, we're working with ANZ to enhance the way they keep information about data sharing to make that more robust and consistent. And before someone asks me in a question about the National One Stop Shop, yes, we do talk to them. In fact, Kristen Kang, who was working for AADC on this project, is now working in the National One Stop Shop office. So we've got a spy on the inside, and obviously HDA we need to keep in tandem in its work as the One Stop Shop evolves. This is the just one more bit of information about that data sharing frameworks project I mentioned. There's a toolkit, there's a guide, which is a generic kind of approach for people that are new to it. It gives all the steps in the process. There's an ethics and submission review guide, which is for ethics review bodies. So actually giving, I can't say telling the research ethics committees what to do, but giving them some guidance about what's good practice, and also giving researchers some guidance about what you need to do if you're planning to submit an ethics project to ethics. That includes data sharing. There's a long and complicated governance framework document which goes through all the legal and regulatory requirements in Australia. And there's a data glossary. Now, on the slides, which you'll get after this, and also in the document, there are links to each of those. They're available on Zenodo to download. Um, it's one project, but actually it's been a fairly significant one because, as you can appreciate, those kinds of things could be barriers to data sharing, and we're wanting to try and address those. And I won't go into the data sharing toolkit is very much a whole life cycle sort of thing from the stages of engaging with stakeholders and consumers right through to how you share the data at the end. Again, at a high level, but really useful to make sure that if you're wanting to enable data sharing, we're looking at all the different parts of the life cycle. And the final thing in terms of a helpful resource, perhaps, is that ARDC worked with the NextGen team at the Clinical Trial Centre in Sydney to develop a document which you might find useful, which is more from the demand end. So what sort of things could I use secondary data for? I could use it obviously for things like I could do repeatability, reanalysis, I could do secondary analysis, I could do evidence synthesis. So it takes that sort of view of the value add that secondary research could have. So that's a document that's available from ARDC. And the final sort of, this is almost a plug in a way, but one of the things that's been important is to engage the NHMRC. I've even had clinical researchers tell me, well, until the NHMRC tells me to do this data sharing, I'm not going to do it. Overseas, that is happening, by the way. It's compulsory. But the NHMRC in their open science policy now has included a recommendation, not a requirement, but a recommendation that people share their data from clinical trials and use Health Data Australia to do that. That could give us a flutter response, I suppose, but I think it's good that NHMRC have recognised that this mechanism and this sort of approach to data sharing is of value, and they're recommending it. And that policy, again, the link is in the document we'll share. And I thought finally, I might just give you a sense of what else is happening. So Matt will talk a bit about HDA as it is now, but it might be helpful for you to know what ARDC is planning to do this and to do with this. And the bottom line is we're in this for the long haul. It's yes, we have periodic funding, but HDA is an important platform. It's one of our flagship programs. It's not going to go away. We will continue to support it. Just as I mentioned before, just recently we've started our cohort studies program, which is where we're looking to add to the catalogue that it's in HDA of clinical trial data sets to add cohort study data sets. Now, those of you who work in cohorts will know that cohorts are a bit more complicated and the clinical trialists don't get offended, but I think the cohort studies are actually more complicated from a data and metadata perspective. And also there's no equivalent of ANZ There's no register of cohort studies. So we're going to have to change the way HDA works. So we're in the middle of doing that in consultation with nodes as well. We've also got a government datasets project where we hope we will be listing some AIHW datasets in HDA. So if you're looking for something that's in your related field of study and it's in a government dataset, you should be able to see that in HDA. And then in the planned heading there are a few other things that are in the sort of say 18 months to 2 year kind of timeframe. We will be introducing Phenomics Australia's Phenome Bank and stem cell registry catalogues into HDA. So as a discovery portal, if you're looking for a preclinical model, a mouse model that the Genomics Australia would have in particular disease area, you should be able to see that in HDA. And then similarly with things like the biocommons and bioplatforms for these are NCRIS facilities, colleagues, we're looking at can we incorporate some of the things that they're doing? There's some molecular psychiatry work, for example, being done. We're working out ways that we can incorporate that. And the last point there is HDR UK. Some of you may be familiar, is a not dissimilar organisation to ARDC in the UK. When you search HDR, you can now see if there are any data sets that match your search criteria in HDR UK. They'll come up at the bottom of your search, and HDR UK will reciprocate that at some point in the future. Doesn't mean we can request the data internationally yet, but at least you've got visibility of it, and that's part of a sort of a toe in the water of federated international searches, which we're going to have to do given the international nature of research. And the final things on the right there are just even further ahead. Clinical quality registries are on the radar. If you're going to do cohort studies, you probably would want to do registries. We're working with the Commonwealth around how that would pan out. There's some work being done around registries for those who are in this space around accreditation of registries and linking it to accreditation of hospitals. As that settles down, there's room for ARDC to be involved. So we will probably work on that at some time in the future, and maybe even biospecimens. And again, that would rely on the biospecimen community, but they're already talking to us. So without wanting to confuse you, I guess the point is data sharing has started small for us. This HDA has started small, but very quickly we can see the value of it, and with the community, we're adding capability to it. And the final thing which may just be interesting for people to know in the clinical research space, is that the People Research Data Commons, of which HDA is part, so our Fair Assets program of work, a big part of that is HeSANDA and HDA and the things I've just discovered. But there are two or three other things that I'm going to mention briefly because they might pique people's interest. And they do relate to the process of sharing data. The first one is secure data access. Obviously, if you get approval to share your data and you want to make it available, you have to put it somewhere secure. At Monash, you have a TRE, a trusted research environment established, which Matt is involved in maintaining. Not everybody has those. So we're doing a piece of work across the country to look at what requirements around TREs would be. And in the end, we will partner with a couple of organisations to provide a secure research environment for clinical researchers in particular, but for any researchers. So that's a piece of work that's started. We've also got a really exciting project working on using the OMOP Common Data Model to integrate hospital EMR data for research. We know it works, but to do it on a larger scale, that project is underway as well. And without going into the details, because I'm not an AI ML guy, but there's a bunch of work going around federated machine learning capabilities, again, leaving the data in place and analysing it. So all of which is facilitating this notion of getting data shared more effectively and more efficiently. So that's the QR code for the People Research Data Commons, and that would take you to a sort of overall page that would describe the things I've just mentioned for more detail. I've always got to put that, the standard running joke in ARDC is the last slide has to be subscribed to our newsletter. So I've just done that. I get a tick from the boss. And those are my contact details and the HeSANDA team, the generic email. But obviously this is something that's not just done by me, but by a team of people. I'm one of the people working on this project, and I've had the benefit of being involved in it from the beginning, but there's a team of people, obviously. I've done that really quickly, but I've done that and hopefully that'll spark some interest, and we'll have opportunity to discuss in the discussion. And Carol, what I might do in a minute is I'll post the link for that document that's got all the bits and pieces in it.
Perfect. Thanks so much, Reese. That's fantastic. Really appreciate that. And I think everyone will agree there's some amazing resources that are available on the website, and things that I even didn't know about, Reese. So great work pulling them all together. And I've actually happily been emailing them to a couple of our researchers who've been looking for nice templates recently. So yeah, thanks for the signposting. That's really helpful. Our next speaker is Matt Isaac, who's a senior project officer at Helix at Monash University. Matt has spoken with us before, but I just wanted to say that, he specialises in research data management. He's played a key role in delivering secure and safe solutions for researchers in our safe havens, such as SURF at Monash University. And he has excellent experience in terms of curating data. So over to you, Matt, and thanks so much for joining us today.
Thank you so much, Carol, and team, and thank you, everyone. Bear with me. I'll just bring up my slides. Should be able to see that now.
Yep.
Thank you. Okay, welcome everyone. Thanks for joining this HeSANDA workshop today. My name is Matt Isaac, as Carol just introduced me. I'm Senior Project Officer at Helix at Monash University. Today, I'm going to talk through how to be involved with the HeSANDA project directly. We'll show you how it works from a data custodian perspective and also from a secondary research perspective, looking to perhaps use some secondary data. I would also like to acknowledge the traditional owners of this land. Today I'm talking from Naarm. I acknowledge elders past, present and emerging. Okay, first off, let's talk about eligibility for the HeSANDA project and listing a clinical trial on the Health Data Australia catalogue. While the HeSANDA project will soon expand to cohort studies, and today we will still just be focusing on the clinical trials data and data sets that will be available on Health Data Australia. So if your trial is registered on ANZ CTR and has approved ethics with consent for secondary use of data, then your trial is most likely eligible to be included in the catalogue. If you do not have consent, so for prospective studies where informed participant consent was not originally obtained, it is still possible to get an amendment to the Ethics Committee for a waiver of consent, which can be considered. And we do have some documentation templates that help with any of that as well. Once a project is identified as eligible, the Monash node can assist with extracting the ANZ CTR information for the trial and creating an entry within the Health Data Australia catalogue. If the information is on ANZ CTR, we, as in the HeSANDA project and the Monash node, can pretty much do the heavy lifting from there. How that works in a practical level is in the middle here, we have the Health Data Australia catalogue. On the left, we have the ANZ CTR website where the clinical trial will be registered. The only part needed from the data custodian side would basically be entering into the ANZ CTR website, as I just mentioned, and then notifying the Monash node of eligibility. We will then quickly check, make sure that meets our initial requirements. If it does, and I'm assuming it does at this stage, what we would do is create a digital object identifier on behalf of the clinical trial that will link directly to that data set. We will also create an entry on Monash Bridges, which is a Monash University metadata repository, and that will also link with DataSite, which connects all that information into one repository on Health Data Australia. So it collects all the information on the top left, all the information on the top right, which will be managed by Monash Node, and collects it down the bottom in the Health Data Australia catalogue, all combined for easy access. And what are the benefits from a data custodian perspective? First, it increased visibility. Your trials become discoverable to researchers across Australia and internationally. Second is greater impact. By enabling secondary use, your work contributes to new research questions, new collaborations, etc. Third, you do remain in full control. Nothing is shared without your approval. And finally, it reduces duplication. If other researchers know your data exists, they're far less likely to repeat work unnecessarily, which means more efficiency, more collaboration, and hopefully greater reach for your research. One of the biggest concerns we hear often is my data secure? The goal here isn't to move your data anywhere. it's simply to increase discoverability. The Health Data Australia catalogue does not store the actual data set within the catalogue, only the descriptive metadata about the actual trial. Your data will remain exactly where it is under now, under your control, behind your security systems, and within your governance structures. You decide whether to share the data with whom and under what conditions. We'll just facilitate that through the catalogue and its associated tools. There's also, if assistance is required for sharing the data safely, as Carol mentioned, we do have other platforms as well that can enable that safely through our safe havens and SERP. So as a data custodian, how would you get involved? The process is intentionally simple to make this as easy as possible. If you believe your trial is eligible, please visit the Monash Helix website. I will provide the web address in a later slide. All you need to do is submit the HeSANDA form, which is basically an expression of interest that your trial is eligible. Just includes some basic information, basically title, ANZ CTR, ID, and a description. The Monash node will then review that request, make sure it meets all the requirements, and then, as I showed in an earlier slide, we'll build the Monash Bridges entry, and then handle any inquiries that may come through. Now, I'd just like to switch to the perspective of the secondary researcher. For secondary research, the benefits are also substantial. Many clinical trials collect incredibly valuable data, but unless they've been published or listed in public repositories, nobody knows they exist. So with the Health Data Australia catalogue, researchers can explore and identify many different data sets and that align with their project aims. So this can support new research questions or building richer data sets across multiple trials. It also reduces duplication and faster pathways to discovery. Now, Reece did touch on this briefly, but I'll talk through how a data request can be submitted to access the data for secondary use. So all requests go through a structured online interface. Once submitted, the request is automatically directed to the appropriate node. So if someone was requesting one of our trials that we've listed, the inquiry would come directly to the Monash node, which is at Helix at Monash University. Our role is to check the request for completeness, ensure the researcher has provided all required information, and then we'll forward it to the data custodian for review. This should mean you receive well-formed and complete requests rather than partial or unclear or superficial requests. So what is the actual data that's submitted? They must include project design, applicant information, so who's actually applying, their background, their institution, etc. Need to also submit information on their planned outputs, what they plan on doing, and obviously any IP discussions might also need to take place as well. Ethics will also need to be listed on the request form, and this all helps you assess whether the request aligns with your governance requirements and any data sharing policies you may have. A lot of these questions, they can still, like for ethics example, it is possible to submit the form with ethics pending, and then there might be a bit of back and forth before it's actually approved or declined. So that approval process, who does approve it? Once the request is complete, we, Monash, as I mentioned, will triage it and ensure it is appropriate. Then we will forward it to the appropriate data custodian. If your department has a formal process, you can use those. Otherwise, we can facilitate a review process for you. We can provide templates for communication with the requester and supporting you with any documentation and guidance. Reece mentioned Toolkit earlier. We also have several documents to support that on the Helix website as well. As I did mention, the approval will sit with the data custodian. You can, just a few things that have popped up with previous requests for data. Some researchers may seek in-principle support for a grant or ethics submission, and then proceed with their ethics before coming back with an actual formal request for the data set. That's okay as long as they declare it, and that's purely up to you whether you're happy to proceed with that process. Lastly, I did mention we have a repository for support for all your data custodian and secondary research needs. We provide a wide range of support resources through the Helix website, listed under the Monash node. This includes communication templates, policy guidelines, and direct support for your node if needed. Please visit our website for any inquiries, navigate to the HeSANDA data request page, and please submit a form if you're interested and in listing your trial. Happy to answer any questions, and our team will be here to support you. Before I wrap up, I just want to acknowledge the national HeSANDA partners, Monash Partners and ARD especially, the other nodes across Australia supporting this project. Of course, also like to thank the internal team throughout the length of this project, project sponsors Carol Hodgson and David Powell, and also team members internally, Juliana, Marina and Robab. And thank you all for your time today. As I will also mention just once more, feel free to reach out. Please, you can grab our contact details on the Helix website, and happy to answer any questions, or please submit the form if you've got a trial that you think might be eligible. Thank you.
Thanks so much, Matt. That's fantastic. And I just would like to really echo Matt's thanks to the project team. It's been a fabulous collaboration and great support from the ARDC. So I've been asked to speak with my other hat. So you probably all know me as the Executive Director of Monash Partners, but my other role is actually as a clinical trialist, and I'm the co-director of the Intensive Care Research Centre, which sits here at Monash University, and head of the Division of Clinical Trials and Cohort Studies in the School of Public Health at Monash University. And we've completed many large clinical trials, but I wanted to specifically just speak for a few minutes about one clinical trial that we conducted essentially sponsored through Monash University, but we had 50 sites around the world. It was called the TEAM trial, the Trial of Early Activity and Mobilisation. And this study looked at critically ill patients being mobilised or early rehabilitation in the ICU. And we had 6-month outcomes. So the primary outcome was days alive and out of hospital. Now, the trial randomised 750 patients. We included 6 countries, and the results were published in the New England Journal of Medicine in 2022. It won ACTA Clinical Trial of the Year award in 2023. And, it's just a piece of work that I'm particularly proud of. And the reason that I'm mentioning it is that when we published in the New England Journal, there's a data sharing part of the journal that you have to complete. So people know how to request data for the trial. But, when we were talking about it within our management committee meeting, we thought that, there were some really important reasons that we wanted to put the data for the trial onto the HeSANDA node at Monash so that the data could be shared. And I just wanted to talk through some of those reasons. So the first thing is that the research participants and the community have better contribution of the research without requiring more time and effort. So it means that the data that's being collected, you can put it out there for other people to think about whether it helps answer their research question. And that's particularly helpful for people who don't have the funding to do research themselves, but they have important questions, and access to this data might be helpful. It makes the most out of the data the participants provide. I think it's really important for the patients and the families. Most of the time when patients are critically ill, when we speak to the people who are enrolled in our studies, they say that they want anything that can possibly be learnt from the data to be used. And I think that, when you have a research study, you often ask just one very specific question. So the lovely thing about the secondary use of data, and, we've gone on to publish, so that, and just as an example of this, from our own work, the primary question was, does a higher dose of rehabilitation improve outcomes in critically ill patients compared to a lower or standard care, lower dose of rehab? And the answer to that was no, it doesn't. And in fact, the point estimate didn't favour a higher dose of rehabilitation. And if we just left it at that, there was no difference between the groups and we wouldn't have learnt much. But in terms of secondary use of the data, and because we had ticked, are we allowed to use the data for secondary purposes, it means that we can put it onto the HeSANDA website. But our own team have looked at secondary questions, and some of the questions we've looked at is like, were there particular groups of patients that benefited or did not benefit? And in fact, we've gone on to find that patients with diabetes, type 1 or type 2, are more at risk of mortality with early mobilisation at a high dose compared to a low dose. And they are particularly at risk in this cohort. So we know now when we're mobilising our patients in ICU that we have to be very careful with our patients with diabetes. And we've also looked at, what were the adverse events that occurred and in whom. And we've learnt that the adverse events mostly occurred in patients with cardiovascular problems. And, we wouldn't have known that without the secondary analysis of the data. We've also gone on to look at heterogeneity of treatment effect. So again, are there differences? And we've been able to send out data to the US to be analysed by a different group who are experts in this sort of analysis. And they've been able to identify that if you're on vasopressor medication to improve your blood pressure, if you're heavily sedated, or if you've got diabetes, that again, you're at much higher risk with a high dose of mobilisation. But they've also been able to identify patients who are going to benefit from high dose mobilisation. And those people are people who are less frail, with less comorbidities, and who have a better functional status at baseline before they're enrolled into the study or before they become critically ill. So this secondary use of data is incredibly important. If we just left it at our primary study, we wouldn't actually have learnt much about what we need to do in terms of the type of patients, the dose of the rehabilitation, or who's at risk of adverse events and what we can do to prevent it. And we've learned all of this through the secondary use of data. So we've put our data on the HeSANDA website because I believe that's incredibly beneficial. It makes the most of the data that we've already collected, and that the taxpayers have paid a lot of money for us to conduct this one study to answer this one question. It means that we can answer separate questions again. It makes the most of it for the health services who are trying to improve critical care services, throughout Australia. It makes the most of the data for the patients who have contributed their time and their data into the studies, and, at a time when they're incredibly vulnerable in their lives. And, it means that I think that we're going to improve health outcomes for the whole of Australia because we are making the most of this data. So, as I said at the start, this is something I feel very passionately about. It's something that's actually compulsory in the US. So the US, if you are funded our study was funded nationally. In the United States, if you're funded at a national level, you actually are obliged to put your data on a repository for access. And again, you have to have the right approvals in place and you have to have the right data access. I guess the thing that I really want to emphasize, and the thing that everybody seems to feel very uncomfortable about, is that if you put yourself on the HeSANDA website, that people can just access your data. That's not the case. It's a catalogue. So all that means is that your information, your data dictionaries, your data points are available for people to have a look at to see if they're helpful for their research questions. And then they have to come to you to request the use of the data. You can leave your data in a safe haven. So it's not like your data can even be taken out and used at an external place. So for our studies, it's left on our SERP environment at Monash University. So the individual patient data is de-identified and it can't be taken out of our safe haven. People have to use it within that. And then we have to approve any export, and the exports are only the summary data that they've generated specific to their research question. So I guess I just wanted to really emphasize to people who are feeling concerned about the sharing of data through this platform, it's safe, it's curated, and it's really just a catalogue that allows access. And I think that there are some really important benefits to the community for us all to share data for secondary purposes. So on that note, I think I'll finish. I really just wanted to explain my personal experience with the use of HeSANDA and the sharing of my data. And then I'm going to open it now to the panel. So Reese and Matt, I guess I've got a few questions and I don't see anything in the chat. So Robab, if there's anything that I'm missing, please send me a text just so that I can see. But perhaps I'll start Reese, why don't you talk to us? The ability to search the HDA as a national catalogue of health research projects changes the way researchers can approach a new study or a clinical trial. Do you want to talk a little bit about like how you think, and I guess I've covered a little bit about that, but how do you think researchers can approach a new study or a clinical trial with it?
I mean, I think, thanks, Carol. I think, yeah, you have covered part of it that now you can look there when ultimately you could go and look there first. You'd go and look and see while you're. I think it's in the early stages of designing your study and crafting your questions. You'd want to know what. Obviously, you do literature research, but is there data available? Not just a publication, but you would look. This gives the opportunity to find it. One of the people would have heard of the FAIR principles: findable, accessible, interoperable, and reusable in relation to data. Well, the problem with clinical trials and with lots of research data is you can't find it in the first place. And the notion of having, obliging countries saying you must put this somewhere, findability. So findability sounds simple, but actually HDA contributes considerably to the findability for someone who's starting out to plan their research. And so I think it changes the game a little bit by putting that in your planning stages, thinking about is there secondary data that you could use uniquely or perhaps alongside what you're planning to do in your own research. Just one thing that also occurred to me is sometimes what we're finding is people are making inquiries to HEA about PhD students or perhaps even shorter term research projects. Um, Obviously, if someone trying to do a shorter term project, collecting data from a fresh is time consuming and complicated and expensive. I saw somewhere somebody estimated that using secondary data is about a fifth the cost for your research is about a fifth the cost of doing it, collecting it primarily. And cost is not, I think the things you've said, Carol, are more important than the cost, but that is a factor and the time frame. So I think it potentially shortens the time frame. It helps you to make best use of something that's already available. And I think it actually helps you refine your own research question too, if you're looking at what other data sets are available.
I think to add to that, Reese, there's a lot of medical training programs where they're obliged to do a research study as part of their
Indeed.
fellowship. And I think that sort of access to secondary data is incredibly important for people who are doing fellowships. They certainly have, again, 12 months or a bit more than 12 months, and it's just not realistic to think that you'd be able to collect your own data in that time frame and publish something at the end of it. So I completely agree. I think that's where the use of that data, not just for PhD students, but also for clinician
For
trainees.
trainees, yeah, agreed. Yes.
Yeah. So Matt, maybe I'll just hand back to you. And I just wondered if you would really emphasize for trialists who are hesitant about sharing their data, what are the primary safeguards and the best practices in place to ensure that the data is shared safely and ethically?
Thanks, Carol. Yeah, it's a legitimate concern and fully understand. I think it's best to probably describe how we handle that mostly now at Monash University. So, we do get a lot of requests for access to data, either data extracts from one of our registries or a an output that needs to be analysed. We will put all of these in one of our safe haven environments. So if you are concerned about the safety, we do recommend, and look, we always recommend putting it into a trusted research environment. So at Monash University, we can facilitate a few of those options. We have the Secure Data Enclave, Monash SERP, and the Safe Havens as well. So depending on the type of data and where it needs to go to, there is always a suitable platform to manage that. So for those who haven't heard of a trusted research environment or a safe haven, it's instead of actually handing the data over to anyone else, you provide it in a secure environment, and then they access that secure environment to access the data and can only remove any outputs at your approval as well.
Yeah.
So most institutes should have access to one of these platforms these days. But if you're unsure, please reach out. We can always facilitate and help with that.
Yeah. And Reese, I just wondered if you could just restate the importance of that data sharing as part of the sort of ethical approval process and the patient-informed consent process, just so that
Yeah.
everybody really heard that. I think that's a really important message about how we just need to slightly change our ethics submissions to make sure that we can share data for secondary purposes.
Yes, I mean, Matt, thank you. Matt mentioned, going back to the ethics committee for a waiver of consent. In theory, that's possible, but anyone who's tried to do that will know it's complicated, and it's complicated for a good reason because informed consent is one of the pillars of clinical research. So, an ethics committee quite rightly will take those cases very seriously. So by far the best way to do this is, as Carol said, make sure that your patient information and consent form and your associated ethics paperwork very, very clearly states that the data will be available to be shared, and there can be caveats on that. So, for example, you can say the ideally is you would be able to use it for research in not just your field of research but in others. But sometimes there may be reasons why you've got to limit it to the same field of research. When you ask consumers, are they happy to have their data shared? The number's greater than 90% for the reasons that Carol said. They want their data to be used to the best possible effect. But if you ask them, are they happy for it to be shared with a company? 90% of them will say no, but they are almost all happy to have it shared for research purpose. So really the ideal pipeline is that right up front in the planning stages, the researchers think upfront about the data sharing as an important component, that all of their documentation, they use a PICF that includes that, and the informed one is a good example. And then all of the other associated paperwork makes it very clear. Down the track, you'll still need a data sharing agreement. You'll still need some other documentation at the point of sharing. But again, there are templates for those things available. The other final point I make about the informed BRCF is that there's a guideline document that tricky bit about, well, what should the wording about consent be? Should it be consent for everything? They've actually got recommended wording that fits a couple of different scenarios which you might encounter depending on the type of your research. So it's worth looking at something like that as an example of what would be an acceptable wording around data sharing. But my advice would be best practice is that you always have something specifically about data sharing in all of your consent forms and in all of your processes, so that this can become essentially the common practice. It'll become business as usual.
Yeah, fantastic. And I guess I just wanted to say for early career researchers, I think that funding is really difficult for early career researchers, and access to data can be really complex. I think this is an opportunity for you to really tap into a source of data where you can connect directly through the node to the researchers who are the custodians of the data, and look at whether you can, conduct a project that's much more time efficient and much more cost efficient. My advice to early career researchers would really be to, have a good look at the Monash node, or the Mac node, have a look at the data that's available and see if you can't use data that's already available for secondary purposes. I just wondered if we might finish, both Matt and Reese, perhaps you can both comment. How does this sort of federated model of the HeSANDA nodes, like Monash node, ensure that data remains managed by the experts who understand it best?
Um, I think Matt's touched on part of this as well. The critical issue here is that at no point in time does the data move out of the control of the custodians. And that's a really important thing. Some of you may be aware of a platform called Vivly, which is a very large US platform that includes data that's available for sharing. They have a couple of different models, but a lot of their data is provided to Vivly by the researcher, and Vivly has its own ethics committee. So they actually keep the data as a repository. You don't have to do it that way, but that's a common model that's used in the US. Pretty early on in the consultation process, we realised that wasn't going to be it's not an ideal model, and it's not an acceptable model in Australia. So by far the better model is a federated one, which is a bit more complicated. There are more moving parts. There is this sort of mediation in the middle that has to happen at the node. There's more work for us. But in the end, it's a much more robust and sustainable and secure model, so people can be comfortable that the uses of our data are being assessed by the people at close to the researchers, either themselves or their staff, as Matt said, the custodians. I think that's the advantage of a federated model. It keeps the expertise where it's most appropriate, and most importantly, it protects the privacy and confidentiality of the data.
And Matt, do you have anything you'd like to add to that?
Just reiterating that, what we're trying to do here is just empower data owners and secondary researchers alike. So making it more discoverable and easier to use without removing any of the current governance processes. I think the beauty about the Health Data Australia catalogue is it's scalable. Instead of just having a contact email address at the bottom of your clinical trial publication, you can now just have a proper catalogue where people can review these in a more efficient manner, and hopefully find answers to research questions a lot more efficiently while still maintaining those high standards of security and ethics.
Yeah, and there's just one question in the chat, Reese. I wanted,
Saw that.
would you need it? Yeah, do you want to answer that one about
So,
data sharing agreements? Yeah.
so yes, in theory you would, if because as we've said, the data, the decision about the sharing that data is with the custodian of that particular data set. If it happens to be the same person, then it might simplify it a bit. But the normal practice would be, yes, you would need a separate data sharing agreement for each one. Um, some I think Queensland have done this a bit, and I think other parts of the country are starting to do it. They sometimes have agreements in amongst collaborators. So you might have a group of health services or a group of hospitals, or perhaps one of the ARA translation centres who get together and say, right, if you're in our group and we know who you are, and we've agreed on a common set of wording, then it streamlines the process of using a common data sharing agreement. But you'd still need to specify each of the data sets, and each of the custodians would individually need to go through their governance and sign off process.
Yeah, and Jenna, just to add to that, Monash Partners has an updated data sharing agreement available on our website, which is meant to be streamlined across the partners. So I hope that's helpful to you.
So you're not starting from scratch, because lawyers, I mean, I deliberately didn't mention lawyers, but they're a cog in that process as well, and sometimes can be a slow cog, shall I say? But to be fair, there is a lot of work being done, and Carol's mentioned Monash are doing it, and other places are doing it, because trying to make that as efficient as possible, still robust, but starting with templates, starting with common work processes, and that's streamlining it.
Yeah. And I guess the last thing that I just wanted to mention as a clinical trialist is that because that we are the data custodians, when we do get a data request, we make sure that there is an ethics approval, a data sharing agreement, that there
Mm.
is a clear research question, that it's not just data mining, that the clear research question is answered by the data that's requested. So we don't give out all of our data, we will just give out the data that's required to answer that specific research question. So I think that there's a lot of responsibility back onto the data custodian as to how the data is handled best. And that gives me a lot of comfort that, people are allowed to request access, but we don't necessarily approve it if the request is inappropriate or doesn't answer the research question, or they're asking for data that's beyond the scope of the research question.
Well, they don't. I mean, I've had two emails, and I expect I'll have more from people from overseas saying, "Can we use data from HDA for AI?" Which I restrained myself from writing a rude response, but my response was, well, you're overseas, so you can't do it. At the moment, the rules are this is only for Australian researchers to request. And the second thing I said is, but even if you were in Australia, the answer would be probably no, and that would completely depend on the custodian of the data. So, in other words, what they're wanting is, can you just give us a dump of what's in your in HDA? And I mean, that's just silly, but that those sort of requests are being made, and there are expectations that data will be available for whatever purpose they feel is appropriate. And actually, as Carol said, there has to be a legitimate, research-driven, appropriately structured reason, and then the decision stays with the custodian. I'm really, if we keep doing it that way, I think the risks of misuse and of inappropriate loss of confidentiality and so on is very, very low. I think we've counted those risks really well with this structure.
Yeah. And also just to reiterate one more time that those requests can be made of HeSANDA and the ARDC, but they are not the custodians of the data. They are just the catalogue for the data that's available.
That's
Those
correct.
requests for data use have to come back to the people who are the custodians or the trialists who've run the trial. So I think that's been a fabulous conversation. Matt, is there any last comments that you'd like to make?
No, good. I think we've covered it there.
Fantastic. And Reese, any last comments?
No, I just I wanted to sort of emphasize that this is very much that I really appreciate the support of Monash as one of our nodes and all the nodes across the country. This project has really only happened because of a really good collegial and collaborative effort across the country. It's a big thing to do, and I'm sure that'll continue. But if the other people who are listening are not currently involved, we'd love to include you in the HeSANDA network, either it's through the nodes or here or wherever you are around the country. I think this will begin to work really well when we build that network of people that are participating in it. So thank you to everybody involved, and particularly to Monash for their contributions.
Thanks, Reese, and thanks, Matt, for your time. It's been a great conversation. Have a great day, everybody, and thanks so much for listening. Okay, bye.
Thank you, everyone.
Bye, everyone.